All right, so as many of you may already know, I have a special interest in management of immune-related toxicities and also toxicities of the targeted treatments that you heard about earlier today from Dr. Reddy. I'd like to focus today on a very particular potential risk, which is future fertility, and it's something that I feel like needs a lot more attention and maybe doesn't get talked about enough. So quick show of hands for the people here. I wish there was a way to poll the people who are live streaming in, but quick show of hands, who in this room here has kids? All right, maybe about 50% of you, maybe a little bit more. And how many of you are thinking about having kids or have loved ones who are expecting soon or want to expect soon? Okay, maybe a quarter to a third. I guess I should raise my hand too. Okay, so hopefully this talk will have some resonance for a number of you in this room. So as Dr. Dowd mentioned earlier, there really is no free lunch with these, the currently available therapeutics we have in melanoma. Because at this point I think there's a lot more questions and answers, I'm going to spend the next 15 minutes or so really structuring my talk around the following questions. Number one, why should we care? Is this actually important? Number two, what exactly is the risk? Is this something that we should be concerned about for our patients? Number three, what are the current gaps in knowledge? And last but not least, what are some ways in which we can start to think about how to fill in these gaps? So to address the first question of why we should care, I wanted to play a short video clip of from the Melanoma Patient Network Europe, in which a French lady pretty eloquently describes her perspective as the wife of a man who was diagnosed and treated with immunotherapy for stage 4 melanoma.
Et quand cette maladie est arrivée, elle est arrivée au pire moment. Et pour mon mari, avoir un enfant, c'est le signe pour lui que la vie continue. Si demain je meurs, et elle me dit, bah, de toute façon, je sais, de toute façon, je vais mourir. Mais et si je savais qu'en partant, en mourant, je te laissais quelque chose de moi, si on pouvait avoir un enfant ensemble, peut-être que dans ta tête, tu ne m'oublieras pas. C'est ça en fait, quand on permet à un couple de préserver le sperme ou les ovules aux sécos, on leur permet après d'avoir le choix d'utiliser ces prélèvements ou de ne pas les utiliser. Nous, on ne nous permet rien du tout. On ne nous permet aucun choix. Pire, on décide pour nous. C'est encore pire, on décide pour nous. On décide que l'urgence, c'est de traiter le patient. L'urgence, c'est maintenant, c'est « Oh, il faut y aller là, oh là là, métastase là. » Ouais, d'accord, mais il y a 2 jours, il avait déjà ses métastases en fait. Pourquoi il ne peut pas attendre demain? Aujourd'hui, il va faire son prélèvement et demain, il commence le traitement. Bien sûr qu'il veut vivre, bien sûr qu'il a envie de vivre. Il a envie de vivre plus que tout au monde. Et la maladie te donne encore plus envie de vivre parce que tu réalises à quel point la vie c'est important, la vie est belle et que tu as tellement de choses que tu as envie de faire quand tu as 30 ans. Tu as tellement de choses que tu as envie de faire que évidemment que tu as envie de vivre. Mais tu as aussi envie de te projeter. Vivre, c'est aussi se projeter. C'est aussi imaginer l'avenir. C'est ça aussi vivre.
So the video goes on, but hopefully that gives you at least one boots on the ground view of what that might be like to have started treatment, be doing well on it, and then all of a sudden, oh no, what about this whole other part of my life that I didn't get a chance to think about before? So we do have, I think, the luxury of finally thinking about melanoma survivorship. As we heard about earlier today, the number of new cases of melanoma diagnosed is slowly increasing over time. And arguably with the advent of a lot of these newer therapies, the rate of deaths are declining. So I think over time what we're going to see is inevitably the number of survivors increasing as time goes on. As we just saw in the video as well, I think it's important to remember that cancer, and even specifically melanoma, is not just a cancer of older people. In fact, looking at data that has been published, it's actually the #1 most commonly diagnosed cancer in young adults ages 25 to 29. I also looked at the next category down in ages 20 to 24. And melanoma is actually the second most commonly diagnosed cancer after lymphoma. And the reason this is important is that actually this age group, the 25 to 29 age group, has the highest documented birth rates in the United States. So patients are living longer, there are younger patients living longer, and as we heard about earlier, we're all familiar with using systemic or whole body drugs to treat unresectable or metastatic melanoma. But that being said, we heard about adjuvant therapy as well. So these are patients who are presumably disease-free, having their tumors removed, and then proceeding to get some sort of whole body therapy. And as Dr. Chung also mentioned, we are starting to make forays into neoadjuvant therapy. So these are patients who receive whole body therapy of some category and then have their tumors removed. So again, a widening pool of patients who are being exposed to drug. As a side note as well, immunotherapy in particular has moved well beyond melanoma to include other disease types as well. And I point that out also just to widen the pool of immunotherapy exposed patients and thinking about who might be interested in receiving additional information besides, not only treatment-related information, but thinking about beyond treatment and afterwards. Immunotherapy, I think, poses a pretty unique problem in that we know that it doesn't completely disappear even after your last dose. We know that patients can potentially have onset of late side effects and that those can last for some time. And I think that poses a unique situation when thinking about oncofertility, which is defined here. So moving along, I think it's really important to think about, well, what is the risk? Are immunotherapies and are targeted therapies considered, as we saw here, quote unquote, potentially fertility-threatening treatment? So, does anyone know where this screenshot is taken, from which movie? I guess my yes, that is correct. I should have animated that a little bit better. Yeah, so this is from a Western film, The Good, the Bad, and the Ugly. I should have planned that better. But it's still a useful construct, I think, for thinking about kind of what data currently exists. So the good, I would say, is that anecdotally, and kind of polling our colleagues across the country and internationally, I think we could probably think of at least one of our patients who's gone on to successfully have healthy full-term pregnancy, or who have fathered a child and at least in the short term are doing well. I also came across this published article from a couple of months ago where this group out of Chile actually treated a pregnant woman with combination immunotherapy, ipilimumab plus nivolumab. I think that was pretty brave, but they actually go into some detail about the side effects that were experienced by this patient. It wasn't, as we talked about earlier, a complete cakewalk. She did develop some side effects, including placental insufficiency, autoimmune hepatitis, but it seems like, as of now, the child is 11 months old and seems to be healthy. So that's the good. In terms of the bad, please don't be put off by how busy this slide looks. But the bad, I would say, is that there really is no robust data. There are some animal studies, and certainly there are known animal models that show that maintaining the PD-1, PD-L1 axis is important in maintaining human and animal pregnancies. The downside of that is that there are no human studies, and there also is not a whole lot of data, especially for men, in terms of what to expect. I also wanted to point out on the very far right-hand column that there are existing guidelines regarding contraception and nursing for patients who may be receiving these drugs or have completed a course of these drugs and are looking for guidance there. So then there's the ugly, which I guess is not so much ugly, but I would say more points out the need for ongoing research in this area. The ugly, as I would frame it, really is thinking about, in the absence of data, what can we extrapolate from what is known to more effectively counsel our patients. There is perhaps a mechanism for indirect toxicity for immunotherapy on male and female fertility. We heard earlier about the known endocrinopathies or immune-related toxicities from these therapies. There's this downstream hormonal cascade that controls, ultimately, among other things, our gonadal or sex organ functions, like our ovaries and testicles. I think it's reasonable and plausible to think that fluctuations in those levels could result in some potential harm to those organs. And while I pointed out earlier on that graph the current guidelines regarding use of these drugs in pregnant or expecting people, I think that's also a pretty narrow view. I mean, I think it's very easy to say that, well, if you're pregnant, you shouldn't be getting these drugs, or at least preferably not. But I think, since these drugs were pretty recently approved, that there still needs to be some ongoing work, longitudinal registry data following these patients to see whether or not there are longer-term outcomes from this. For example, looking at pediatric outcomes, these babies who have been exposed to these drugs in utero, and also postpartum outcomes for the women, and whether or not they have, do they have more side effects with subsequent pregnancies, or do they have more side effects during the pregnancy period? I don't think we really have a lot of guidance in that area as the literature currently stands. The other thing I'll mention is whether or not there's any potential direct toxicity of these drugs. I know that here at UCSF, we actually have had a case of orchitis. There was a young man in our practice who was treated with immune checkpoint inhibition and developed testicular inflammation. Sometimes that can be attributed to a viral or a bacterial cause, but in this case, that workup was negative. I'll also point out a study out of, I think it was a joint effort between Brown University and Johns Hopkins, where they actually took a look at a small cohort of men, 6 men who received combination immunotherapy, either ipi-nivo or ipi-pembro, and in retrospect, looking at testicular biopsies from 3 men, and these were pretty young, so they really should have had no external reason to have no sperm production, but they did notice aspermatogenesis or failure of sperm production in those 3 men. Here at UCSF, we've tried to put together some prospective information to help round out that picture. We do have a protocol here that allows for men who are starting immunotherapy to provide baseline and on-treatment semen samples. So this is definitely an ongoing effort, and this is very preliminary data, but I just wanted to show you these charts from 2 representative patients who have enrolled on this trial so far. I'll draw your attention to the orange line, which is sperm concentration, and you can see that over the x-axis, over the horizontal line, over time in weeks, that there does seem to be some change there. Again, this is really preliminary, and I think ideally I would love to expand this effort to include correlative serum data, blood markers, certain hormone markers, to get a better, more granular idea of what exactly is happening. But again, this, combined with the study that I cited earlier, it does at least provide, I think, a lot of food for thought. This is also a very busy slide. I just didn't want to forget about the other major category of therapy for advanced melanoma. So Dr. Reddy went over already in great detail there are 3 different BRAF and MEK inhibitor combinations currently approved by the FDA in the United States. I think it's important to note that in general, all of them do carry teratogenic or embryotoxic risk. And because of that, again, drawing your attention to the far right column, I think it's just important to note that we advise that folks, to not plan on conceiving while on treatment and also for a certain period of time after treatment. Because those timelines vary widely, you can see 2 weeks after the last dose, 4 months after the last dose, just something to pay attention to and discuss with your provider if you're at all unsure. So So that's the good, the bad, and the ugly. I wish it was more good than bad, but I think that does beg the question, of course, why don't we know more? I think the answer to that question is complicated and pretty complex. There have been a number of studies examining why that's the case. Just to summarize, and open to thoughts from some of you in the audience as well, but one of the major things I think is really an inadequate knowledge base. I've tried to summarize what is known in the field thus far, and I think that we have certainly a lot more to go. There's an inadequate knowledge base about the granularity of the risk. Should we be referring people for fertility preservation? That is, what options do we have for fertility preservation? What is the cost of those? It's very expensive. Should I be shelling out for these if it's not necessary? Those are just some of the questions that come to mind. As we heard earlier in the video, there's also this sensation of or concern of a delay in treatment, that pursuing some of these preservation options could potentially result in a delay to care. Certainly on the provider end, especially when we're busy and running around clinic, there are also time and resource constraints. To be honest, I think, and whether this is wrong or right, I think really depends on the clinical situation. But in the hubbub of trying to start someone on therapy, there are often a number of things that need to get done. Labs for safety, imaging, making sure that people understand side effects and infusion schedules, oral dosing schedules, all those kinds of things. And very often, counseling about what might be perceived as less important in the moment, often counseling about those things can fall to the bottom of our list of things to do. Also important to note the role that bias might play into it. I think there have been a number of studies showing that patients who are younger are perceived to have a higher income and education level. Also, I think are prompted or prompt their provider more often to be posed the question of whether or not fertility preservation is something that they've thought about. Of course, there are also systems barriers. Going on the resource issue, not every cancer center has a defined process by which to identify and refer patients to fertility specialists in a timely fashion. And even when that does exist, for example, here in the Bay Area, sometimes that geographic distance can be cumbersome. I would also add that even within UCSF, where we have the advantage of having access to fertility specialists, that even within San Francisco, that can be hard. If I have a patient who's being treated at the Mount Zion campus, and then the fertility specialists are over here at Mission Bay, during rush hour traffic, that's a 30-minute drive across town, so that can be difficult as well. Insurance coverage and cost is also definitely an issue. These can be quite expensive. This was taken from the Alliance for Fertility Preservation website. And you'll note that, especially for storage, these are not just one-time costs. These are ongoing costs that are cumulative over time. In terms of insurance coverage, I would say that the last time I checked, I believe only 15 states in the U.S. right now currently mandate insurance coverage for fertility preservation. In California, currently we have a mandate to offer, but not to cover. So, what should we do about this? This could be a whole talk in and of itself, but I certainly think that education on both the patient and provider ends about the potential for risk and also available options is very important. Just going on the previous slide about the lack of mandated insurance coverage for this, I think there's certainly a lot of legislative and advocacy efforts that could be considered. And then really, I think the remainder of these bullet points have to do with partnerships. Partnerships internally within institutions, externally between institutions, and also, of course, partnerships with our regulatory groups and certainly with patient advocacy groups is very important. I don't think we're going to be able to move the needle without those relationships. Certainly, even talking about it today, I think, is an important first step. Raising awareness, I think, can't be overlooked as a very important first step. So, takeaways. I would say that I struggled with some of this, but I think overall for the patients in this room or caregivers of patients, I think there is this blanket statement that trying to conceive is not recommended during treatment and for a varying period of time after treatment. I would say that, of course, depending on the clinical situation, there are ways to get creative, but in the absence of information, I think this is the safest way to go. While one could also argue that maybe it is your doctor's job to bring up this very important issue, I would also say that wherever possible, advocate for yourself and your loved one. Sometimes doctors are human. We are thinking about things that we may perceive as more important, and if you believe that this is something that's very important for your future, please speak up. On the oncology provider end, I would say that, again, because of the relative lack of data in this area, that we should definitely be counseling patients about the potential risk of treatment infertility. At the same time, not forgetting to refer patients to our fertility specialists, even if folks express some ambivalence or maybe even disinterest in this. Referrals are easily canceled, appointments can always be adjusted, and I think it's important to get people in the system sooner rather than later. Last but not least, more research effort and collaborative effort to better define this problem so that ultimately we can do a better job of counseling all of you. I'd like to thank the folks at UCSF. This is also a more up-to-date picture, I think, of our research team. I think we need an updated one. And I'd also like to give a shout out to my colleagues in male reproductive health and the Fertility Preservation Center, Dr. Jim Smith and Dr. Mitch Rosen, who have been helping to push this effort forward. Very happy to address questions at the end of the morning, and if any of you want the full link for that YouTube video, I'm also happy to provide that. Thank you very much.